a viral infection, which causes what we used to think was facial nerve paralysis of unknown cause.
So what you have to do then is you're not going to fix the muscles. They're okay. You're going to fix the nerves.
We're going to go after the
Well, how do you find which nerve? I mean, what do you do?
Well, what we've seen is that the nerve going to the facial muscles remains intact. It's there. But again, the electricity isn't going through the nerve to the muscles. And unfortunately, we can't get the brain to send electricity through that nerve to the muscles from its original connection. So we have to use another nerve, a nerve that's working in the face, and hook up that nerve to the facial nerve. And let me show you here which one we use. This is a diagram of the facial nerve as it comes out of the skull, and it goes into the face and innervates or touches the muscles of facial expression. Now, we know that this nerve, while it's intact, while the fibers are still here, unfortunately, electricity from the brain is not able to go through this nerve. So we use this nerve here, called the hypoglossal nerve, or the nerve going to the tongue. We use this intact nerve as a means to get electricity from here up into the facial nerve. Now, there are a variety of techniques that can be used to do that. The first one was simply to cut the hypoglossal nerve, the tongue nerve, cut the facial nerve, and then you actually swing the two together. The problem with that, as we can see, is that the nerve going to the tongue has been interrupted. Mm-hmm. So the tongue gets paralyzed. Furthermore, this is a very, very hardy nerve with lots of energy. So by connecting the two together, you're sort of putting, if you will, a 240-volt connection to 120-volt. And the face can get it can become spasmed and be almost too interactive. So another idea was developed, and that idea was to not use the entire nerve, but just use a portion of the nerve. And if you splice just 50% or 40% of the nerve, keep at least 50 to 60% going to the tongue, and then take a graft from somewhere else in the body, and you could connect just 40 or 50% of these nerves up into the facial nerve. And that gave an even better result while not sacrificing the tongue. However, it was two connections, so there were two potential points of failure, and the nerve taken here as the jump graft, as we call it, clearly resulted in a defect or a deficiency in another part of the body. So looking at this, we thought of a new technique. We said, well, why don't we just take the nerve from the skull and attach it here to the nerve going to the muscle of the tongue. And while it looks like it can be done quite simply here in this diagram, in reality, it's not so simple. This is just too short. Interestingly, the facial nerve, however, travels in a circuitous fashion within the bone before it gets to the brain. So we said, hey, why don't we actually just let's drill out the bone and unroof the bone and just peel the nerve out of the bone, which would give us enough length, and then attach it to the nerve down here going to the tongue. And that way we would only have one connection, and we wouldn't have to sacrifice a nerve elsewhere in the body. And that's depicted right here, taking the facial nerve from its connection to the brain and connecting it down here.
That would involve quite a bit of surgery, wouldn't it?
It does. Dr. Thomas Rowland, who was the originator of this technique, is my associate and is a skull-based surgeon at New York University School of Medicine, and he does a fabulous job with dissecting this nerve from where it exits out of this temporal bone all the way up towards the brain, carefully dissects it out of its canal and peels it out in a really spectacular fashion.
This must be done through what? Through microscopes? I mean, you're dealing with a tiny area right in there.
That's correct. It's extraordinarily, painstakingly meticulous work because we don't want to injure the nerve. We have to pull it out and keep it preserved in its normal, healthy state. And so we use microscopes and instruments that are extraordinarily small. And when we sew these connections together, we're using sutures that are smaller than the width of a hair.
What kind of patients would you use this surgery on? I mean, what types of problems would you use?
Most frequently, we use this in individuals who have had brain tumors, particularly acoustic neuromas, which are often benign tumors that sit right next to the nerve, the facial nerve, right next to the nerve responsible for the animation of the face. And in removing that tumor, unfortunately, the facial nerve can get injured. Frequently, when it happens, the nerve comes back by itself. Unfortunately, there are occasions when the nerve is permanently damaged.
Would you use this in stroke and other forms of neurological problems?
Stroke, it can. We have not used it in stroke patients, and often stroke patients recover quite well on their own, or they have damaged a variety of nerves, making this particular reconstructive effort less likely.
Now, you have some pictures of the surgery, which is, I just want to tell the audience,
yes,
we're going to show some pictures of the surgery. So run us through that quickly.
My
Tell us
pleasure.
what it is.
It is quite graphic. The first thing we're going to see is, this again is viewed through a microscope. The front of the head is here, the back is here, the feet are down here, and the top of the head. But of course, this is focused quite closely to the head. And this is the bone right behind an individual's ear called the mastoid that has been already operated on and removed. And we see in this white pattern right here, that's the facial nerve as it courses from outside of the skull in towards the brain. Mm-hmm. The first thing that we'll do is very carefully take the bone off of this nerve. Dr. Rowland does this in a spectacular way, and peels the nerve, out of the bone. This is the nerve laying in its original position, and we take that and flip it down into the neck where we're going to connect it to the nerve that goes towards the tongue.
This kind of surgery takes how long?
Anywhere from 2 to 4.5 hours.
And what is the success rate on this kind of surgery?
We're getting quite good at getting at least symmetry at rest, because there are two different types of paralysis. There's the paralysis where an individual is unable to smile symmetrically or close their eyes, and then there's the paralysis where at rest the individual is looking at you and one side is drooping. So to get the second, if you will, to get the second paralysis fixed, getting symmetry at rest, we've gotten very good results. In reanimation, in getting the face to actually work in symmetry, we've had also pretty good success.
Okay, we're going to take a break now. We'll come back, and you have some examples of patients before and after, and we'd like to see that. So stay with us, and we'll be right back.